Okay, actually, our patient will prescribe the chest pain, not like I have a pain in my chest. It's not like that, guys. Actually, if the patient presented in the ER, the patient will use a lot of words to describe this pain in the form of pressure, tightness, or just discomfort in his chest, or shoulders, arms, back, upper abdomen, or jaw. He must consider it. This is as a chest pain, and this is will remember, a chest pain, C for chest pain is more than pain in the chest. H is high sensitive troponin. Don't forget it as a cardiac biomarkers, especially if you want to exclude life-threatening condition. E, early care could save a lot of patients, especially presented by acute chest pain. You must exclude life-threatening condition. S for sharing, you guys. We must share our decision with a team. It's not a solo, it's just a team. Don't play solo, play in a team. So S for sharing. T, testing. If you need specific testing, which is further testing to confirm your diagnosis or to exclude some causes of a chest pain. B is the pathway the patient will take. Actually, after initial evaluation, if the patient is diagnosed with, if you reach a certain diagnosis, the patient should follow a certain pathway. A, associated symptoms, especially in specific groups like females, like elderly, it's very important to care about the associated symptoms. I, you must identify patient at risk in non-cardiac causes of chest pain. Nowadays, we use cardiac and non-cardiac. We didn't use atypical chest pain anymore. We used to use typical and atypical chest pain to describe pain not fulfilling the criteria of typical chest pain. Nowadays, it's a cardiac or non-cardiac. S, the structure risk assessment. We must do a risk assessment for our patient who presented by acute chest pain. So remember it, chest pains. It's not pain. So we have a lot of causes of chest pain, guys, and how to think like a doctor. Who having the chest pain? It's his age, his gender, it's young age, it's elderly. What? The chest is formed of many organs. We have the lungs, we have the heart, we have the musculoskeletal part, we have the back. Which organ we should think about? Why we are asking? And its correlation. How you must correlate with the pathology and what are the red flags. The red flags of the patient, you must do something very rapid. The patient couldn't wait for assessment on a slow way, or sending him to do sophisticated investigation. This is a life-threatening condition, and you must discriminate between different causes and check if there is any error and summarize the case of the patient. And at least you must have 3 differential diagnoses at the end. This is how the doctors think if he chest pain. So what is chest pain? As I told you, it's not only a pain in the chest. We have at first, it's cardiac or non-cardiac. Yet, we didn't use a typical chest pain anymore. This is according to the American guidelines, the recent. So, what are the causes? What is the causes of a chest pain? I told you the chest is formed of many organs, the heart, the lungs, parts of our GIT, gastrointestinal, musculoskeletal pain. We have psychogenic and neurogenic causes. The heart is formed of the heart itself, the vascular system, mainly 2 major blood vessels. Okay, we have the aorta. From the aorta, we have the coronary and pulmonary artery. From the pulmonary artery, we have pulmonary embolism. From the aorta, we have aneurysm, we have dissection or dissection, and we have acute coronary syndrome and chronic coronary syndrome. And this is the coronary. how the valvular lesion could lead to chest pain by different mechanisms. Different from acute kidney syndrome, aortic stenosis can lead to chest pain. Mitral valve prolapse can lead to chest pain. Maybe a patient presented by mitral valve prolapse, but chest pain, just suffering from mitral valve prolapse. Don't forget the heart itself. The heart is formed of 3 layers. Pericarditis, not pericardial effusion, guys. Pericarditis, myocarditis, and we have a chest pain, cardiac tamponade. Cardiac tamponade is a form of cardiac, and it's an emergency condition. Could be presented by chest pain. Why not? Don't forget something called Takotsubo or broken heart syndrome. Broken heart syndrome. It's Takotsubo cardiomyopathy, and it's specific, and it's not common in our region. It's and not in our country, and underdiagnosed, and need specific criteria. Maybe if you are going to be a cardiologist. So, what is the pulmonary causes of a chest pain? The lung. We have pneumonia, TB, bronchospasm, malignancy, asthma, for example. The vessels, pulmonary artery. Don't forget the pleurisy. It's very common to have pleurisy and inflammation in the pleura. GIT symptoms. We have the esophagus. The main part of the GIT in the chest is the esophagus. Esophagitis, esophageal spasm, rupture, impaction. It's very important. And don't forget that the patient may have cholecystitis, and cholecystitis were referred mainly to the right shoulder. This could be misdiagnosed as, yes, we have a chest pain due to cholecystitis. Why not? The patient suffer from chest pain due to cholecystitis, musculoskeletal pain, costochondritis, for example, rheumatoid diseases, osteoarthritis. Sometimes the patient has cervical disc. And don't forget the psychogenic and the neurogenic causes. Oh, we have a lot of causes of a chest pain, actually. How to differentiate, how to take, and we have life-threatening condition, like esophageal rupture, for example, like acute kidney syndrome, aortic dissection, pulmonary embolism, tension pneumothorax. So we have to act very rapid in some cases, and we have a lot of causes, and we have a lot of causes of a chest. Despite that most of the patients presented to the ER with a chest pain have musculoskeletal pain or non-specific chest pain, we must early care, guys. A chest. C for chest pain is more than a pain in the chest. T for troponin. Don't forget early care. E for early care of symptoms. If a patient suffers from acute symptoms of a chest pain, don't forget, don't hesitate to call for 123 here in Egypt. If you are in USA, you will call for 911. It's very important, especially if the patient collapsed, have dyspnea, have distressed. This is very important. We have to share awareness among the public to identify the alarm signs of the heart attacks. Okay, so if anyone developed chest pain, we must call for 123 here in Egypt. We must exclude life-threatening condition. This is meant by early care for acute symptoms, especially if it's acute and associated with collapse or discomfort. Okay, and we have to, yes, it's very important now. So if we have a patient presented in the ER, what we are going to do to evaluate him? Okay, initial evaluation of any patient must exclude history, examination, and we should send him for some investigations. But if we have a pain, acute chest pain, we must do it very quickly. And we must be focused. We didn't have time to take full history. We didn't have time to do full examination and ask for a lot of we didn't have time, guys. We must exclude at first life-threatening condition. This is very important if we and this is very important algorithm. This is by the American College of Cardiology. Yes, we have acute chest pain. No, it's a stable, it's a chronic, it's not acute. So it's a stable chest pain. Send him for the office, send him for the clinic for further investigation and assessment. If you have time, okay, but it's not. If a patient have a stable chest pain and not acute, and for a lot of time, it's not here in the ER. ER for the acute chest pain. You have to take history, focused history very fast, and do physical examination. And you must um, focus on the cardiac examination and chest examination mainly, okay, and do ECG within 10 minutes of the arrival of the patient. So if after doing the ECG and taking the history and do the physical examination, we'll do risk assessment. And after the finding, this patient have cardiac chest pain or non-cardiac. And this is cardiac, is acute kidney syndrome or other syndromes. It's acute kidney syndrome, what type? STEMI or non-STEMI? SCT segment elevation myocardial infarction or acute coronary syndrome with ECG changes other than SCT segment elevation myocardial infarction. If we have a STEMI, we will follow the guidelines of STEMI. We send him for revascularization according to which center the patient near to a primary PCI center. We will send him for revascularization according to the pathway and the protocol in your hospital. This is very important. Non-STEMI, we are going to send him to the coronary angiography because he is very high risk patient, or we will go for conventional medical treatment. This is very important. Or we could suspect this patient maybe have acute aortic dissection or pulmonary embolism or have a valvular heart disease, and this patient may have acute myopericarditis. This is very important. We can go for further investigation if we suspect something, but only for investigation. Do you think that the history and physical examination will help us in diagnosis of other cardiac causes of acute chest pain, or to exclude non-cardiac causes, or to exclude or confirm these life-threatening? At first, we must take history. How to take history? Differentiate. And these slides show you, according to the age in ED, different ages. Okay, this is patient according to the patient in different ED. From 18 to 44 year of age, non-specific is the most common. If you look, this is blue in this diagram. The blue one, non-specific, the chest pain. But according to the age, the coronary atherosclerosis or acute kidney syndrome will increase, aortic dissection. So the most common cause of a chest pain in emergency department will be non-specific. This is very important. It's non-specific, but we have to do risk stratification. We have a lot of causes of chest pain. This is according to the age. If a patient presented, but nowadays, guys, especially under stress, junk food, and obesity, we have a lot of risk factors common in young age. Don't underestimate women and youth. Don't underestimate them. Actually, we see a lot of these days we see a lot of patients presented by serious life-threatening condition. But these are the statistics. So this is according to the age. The criteria of the pain, the site of the pain, increase the probability of ischemia or decrease the probability of ischemia, just the character of the pain and site. If it's a central pressure in character or squeezing or gripping or heaviness or tightness and stress related or exertion and retrosternal, this is increase the probability. This is a typical chest pain. If left-sided, dull or aching, maybe it's chest pain. We have moderate probability. Stepping, this is the yellow color. But if it's right-sided, tearing, gripping, burning, sharp, fleeting, shifting, pleuritic, positional, it's a decrease the probability that this chest pain is ischemic. This is the character of the pain. The angina, pain ودiscomfort وheaviness وtightness وpressure, constricting وsqueezing, while sharp pain increase with inspiration and laying spine, mostly pericarditis. It's very important, besides the nature of the pain, you have to ask about the onset and duration. Usually anginal symptoms gradually build in intensity. It's not started severe from the start. This is meant by this sentence. Anginal symptoms gradually build in intensity over a few minutes. It means what? Means that the anginal pain is not severe from the start. It increases over a few minutes, while sudden and severe from the start and tripping chest pain, you have to suspect acute aortic syndrome or acute aortic dissection. Fleeting pain, few seconds, unlikely to be ischemic heart disease. The location is very important. Localized pain and very limited below the umbilicus or hip, radiating to the umbilicus or hip, is unlikely to be due to myocardial ischemia. Very limited area. Usually the chest pain is not very limited, okay? The site will be retrosternal, radiating to the left shoulder and the ulnar side of the left arm. Severity of the pain. It's very important. Severe from the start, sudden and severe, or it's built over few minutes. Anginal pain or anginal pain, it's built over few minutes. Why? Acute aortic dissection, it's acute from the start. Precipitating factors. Ischemic myocardial ischemia or acute kidney syndrome. The trigger of the angina, mostly exertional, physical or emotional stress. Don't underestimate the emotional stress, guys. And don't underestimate this patient have emotional stress or under emotional this stress to exclude the acute kidney syndrome. Why not this patient have ischemic heart disease and the angina is precipitated? This is a precipitating factor. This is the trigger. This is the cause of the chest pain. So if any female presented by distress, don't dismiss her without following the algorithm and excludes serious life-threatening condition and causes of chest pain. Because usually we underestimate young people and women, especially mostly the precipitating factor will be emotional stress. Even very young age nowadays, exclude at first, do an ECG, send for cardiac troponin at first before dismiss a patient or before risk stratification of this patient as low risk. Usually, acute kidney syndrome is precipitated and triggered by minimal exertion. This is instability. Tenderness or positional chest pain, usually musculoskeletal. If the patient have chest pain, if he laying on his left side, left lateral position, right lateral position, leaning forward on the back, this is mostly musculoskeletal pain. The relieving factors. If the patient told you I take for example before getting to the ER, before my doctors, my physician asked me to have to take sublingual nitrates. If I give him sublingual nitrates, this could be a good provocative test. If the patient relieved, this shouldn't be a diagnostic criteria. But it's not necessary if the patient relieved by nitroglycerin, but it helps, guys. Actually, on clinical basis, it helps. But it couldn't, if the patient relieved by intake of nitrates, not 100% confirm that the patient have acute kidney syndrome or ischemic, okay? Associated symptoms is very important. It's not just syncope or pre-syncope or lightheadedness, palpitation, sweating, upper abdominal pain, epigastric pain. Take care of the associated symptoms, especially in elderly, diabetes, and women, because most of them will be presented by the associated symptoms more than presenting with the chest pain itself. So chest pain is more than a pain. This is a signs of heart attack or acute kidney syndrome, tightness, pain, Pain is a wide process, dizziness, fainting, palpitation, sweating and nausea, breathing difficulty. This is a dangerous signs. Should be go and seek medical help in the emergency department. After that, you have to do a focused physical examination. Usually in a patient with acute coronary syndrome without complication, the examination could be free, nothing. But serious condition could be excluded like esophageal rupture, pulmonary embolism, aortic dissection. Science could help you to exclude these. So please examine the patient. Usually in acute kidney syndrome, there is nothing normal in uncomplicated cases, but the patient if have severe or STEMI, maybe have mechanical complication, cardiogenic shock, acute mitral regurg, if the patient have a complicated cases, but we talk about non-complicated cases. The pulmonary embolism will have clear chest, we have difficulty during inspiration, we have tachycardia and dyspnea and pain. This is triad of pulmonary embolism with a clear chest. Aortic dissection, the patient will have, if you have pulse differential, if you go for the pulse, there will be, if you examine the right radial pulse and left radial pulse, there is impairment, there is inequality of the pulse. This is very common. Syncope, more than 10% of the people with aortic dissection could suffer from syncope. Acute aortic regurg, guys, more than 40. It could happen in type A aortic dissection in the ascending aorta. Up to 40 to 75% of the people will have acute aortic regurg. Chest X-ray will help you from the history. If you suspect the history, severe from the start, abrupt onset. In chest X-ray, you will have widening of the mediastinum. This is the life-threatening condition. This slide show you the causes, life-threatening causes of chest pain. Acute kidney syndrome, pulmonary embolism, aortic dissection. Before dismiss the patient or search for other causes of chest pain, as we mentioned before, please exclude these causes. Esophageal rupture will be associated with subcutaneous emphysema, pneumothorax in about 20% of the patient, unilateral decreased or absent breath sound, and vomiting. What about other causes? Non-coronary but still cardiac causes. We will listen to the murmur. Aortic stenosis, aortic regurg, and HOCM. Pericarditis will be presented by fever, chest pain in supine position, friction rib. Myocarditis, we will have gallop, S3 gallop, and heart failure symptoms. Esophagitis, we will have epigastric tender, peptic ulcer. Gallbladder will have a Murphy sign and right upper quadrant tenderness, and there is a pain in the right shoulder, maybe radiating to the right shoulder. In pneumonia, we'll have fever, crepitations, friction rib, we'll have dullness on percussion. Pneumothorax, there will be dyspnea, pain on inspiration, and unilateral absence of the breath sounds. Costochondritis, it's very important. Tenderness but don't forget, the patient may have chest pain associated with costochondritis. Herpes zoster, we will have the rash. It will take dermatomal distribution. It's very characteristic rash, unilateral and dermatomal distribution, and triggered by touch and very pain. Exclude herpes zoster. It's not uncommon. Within 10 minutes during taking the history, we must have ECG. Unless you are very sure this is patient with not cardiac or not life-threatening condition. Even in other causes of life-threatening condition, pulmonary embolism have certain ECG changes. Acute coronary syndrome will be excluded. Aortic dissection associated with coronary dissection will have ECG changes. It's very important to do an ECG for any patient with acute chest pain, not acute coronary syndrome. Very, very important. It's a class 1 indication, guys. Level of evidence B. Don't. If you suspect acute chest pain, don't deal with it in your clinic or your office. send the patient to have an ECG and cardiac troponin in the ED, especially if you suspect STEMI. According to guidelines, we should do it within 10 minutes of arrival of the patient. This is the other indications according to the guidelines why we should do an ECG and we have STEMI or non-STEMI. And if we suspect it, don't forget to do V7 to V9 leads. If you suspect the posterior wall myocardial infarction, sometimes a patient presented by acute kidney syndrome without ECG changes or ECG changes other than usual, يعني, it's called posterior wall myocardial infarction. Sometimes, if the patient presented by chest pain and the ECG is normal at first, but the patient is high risk for acute kidney syndrome, you have to do serial ECG, guys. Yani don't just, not only one ECG is enough. You should do serial ECG for serial troponin. And this is how. If we have acute chest pain, evaluate stable. Again, it's okay. Send them for the office. It's not acute chest pain. You are sure. Do have a history, very focused history. Do a physical examination. ECG with 10 minutes of the arrival. After the ECG, this is ECG mostly indicate a cardiac cause, acute kidney syndrome STEMI, follow the pathway for STEMI, or acute kidney syndrome other than not STEMI, follow the other pathway. Acute aortic syndrome is suspected, pulmonary embolism, acute myopericarditis, or valvular heart disease. This is very important. Again, this is the finding of a chest of ECG in a patient with acute chest pain, STEMI, SCT segment elevation, myocardial infarction. But you have to take into consideration, not all the SCT segment elevation is MI and chest pain, STEMI. Pericarditis can cause diffuse SCT segment elevation, but they have certain criteria. ECG with pericarditis is different from ECG in STEMI. Diffuse, and there is no reciprocal changes, the shape of the SCT segment elevation, the BR segment, and certain, we have a lot of criteria to differentiate. SCT segment depression, T-wave inversion, biphasic T. We have to follow up the guidelines for acute kidney syndrome other than SCT segment elevation. The ECG is normal, repeat it, and do cardiac enzymes, biomarkers. T for troponin. Don't forget it. If we didn't have a high sensitive troponin, we could replace it by creatine kinase, not the general one. We have to take the CKMP, the isomer for the heart. If we suspect in high-risk patient or you suspect of C-wall myocardial infarction, we have certain criteria in ECG. Do a non-specific or normal ECG, do lead, ask the nurse or do it by yourself, lead V7 and V9. Put it on the back to detect posterior wall myocardial infarction. If you have arrhythmia or new arrhythmia, you have to follow the guidelines according to the type of. What is the role of a chest X-ray in a patient with acute chest pain? Maybe pulmonary causes, guys, aortic dissection, but it's not the gold standard. If you suspect a cardiac or pulmonary cause of the acute chest pain, chest X-ray could be helpful. Yes, again, the biomarker you should do in patient with acute kidney syndrome is high sensitive troponin. You must do it in arterial 0, 1, 2 hours. Okay, you could repeat it, especially if the patient is still symptomatic. After 2 times, you could exclude the patient have ongoing myocardial necrosis or ischemia. If we didn't have it, you could CK or CKMB. So, how to do risk stratification of the patient? This is patient presented after taking history and doing physical examination. We have to do an ECG. This is obviously non-cardiac cause, so we have to do non-cardiac testing. No, this is a cardiac cause, ischemic or non-coronary. Ischemic acute kidney syndrome, send them for troponin. It's low risk or intermediate or high risk. High risk, send them for coronary angiography. Intermediate risk, maybe we need further investigation before dismissing him. We have moderate to severe risk also. Low risk, we can dismiss him without further testing. It's very important, guys, before dismiss the patient from hospital, we have to decide this patient needs further investigation now or later, or we'll dismiss him without further investigation. This is according to the risk stratification. And the risk stratification according to the risk scores. We have many risk scores according to the gender, according to the race, according to the country, according to the hospital. According to the protocol used in your country or your hospital, you will use the risk score, and that is the end. So we have a lot of causes of chest pain, cardiac and non-cardiac. And non-cardiac, we have coronary and non-coronary. It's very important to triage the patient in efficient way and exclude life-threatening condition. This could be done by taking focused history, doing physical examination, and send the patient for investigation. You didn't have to go for, you have to choose the investigation according to the suspected cause. ECG is very essential, and the cardiac biomarkers, you can do it for all the patients, even low-risk patients, you have to do it, even low-risk patient, okay? If you are sure it's not cardiac, it's okay. Yeah, the guidelines maybe not recommend doing ECG. It's not class 1 indication. But actually nowadays, if young patient presented elderly or women with what we call as before atypical chest pain, we must do it. We must do ECG and troponin, okay, to confirm the diagnosis, okay? Exclude life-threatening condition is very important. Time is very important. And thank you, guys. See you soon.